Welcome to this mini video on analgesia. So the learning outcome that I want you to take from this particular mini lecture is to be able to explain the different drugs that we use for treating pain, specifically acute pain. Okay, so it's acute pain and nociceptive pain. And I really want you to know the mechanism of action. And how do you do this? Well, we'll put it together on the pain pathway. So this is a busy slide, but I'll walk you through it. So to start with, you've looked at Yun's lecture, and she's done the 4 main steps for the pain pathway. We know that we have nociception. We know that we have transmission. We know that we have perception. And we know we have modulation. Now I'll quickly walk you through this, and then we'll show you how the drugs work. So out here in the skin, let's say on your finger, you were to cause some degree of tissue injury. Now, once you injure yourself through this kind of tissue injury, you need to pick up that injurious agent through nociception. So this is what these are, through nociceptors. Now, there's 2 categories of nerve fibers that pick up pain. We have C fibers and alpha delta. So the C fibers picks up extreme heat and direct painful stimulus, like let's say you were to, with your finger, prick it with a thumbtack, whereas an A delta would be cold or maybe excessive force, like if you were to slam it in the door. Okay, so in any case, we have the activation of the nociceptors, and then it sends action potentials down these axons. So now we go to transmission. Up towards the spinal cord, in the area that would receive that area of skin, and then that would synapse, which means that first order, the primary neuron, would end. So this here is a synapse, which we're zoomed in here, and I'll walk you through this in a second because it's quite busy. So from here, we then go to a second order, which is this purple one, and we go across to the other side of the spinal cord, into the white matter, up into the brain, where we end again in the thalamus. So then we have a third order where we go now out to the perception. So the brain now makes sense of what's just happened. So some signals go to the somatosensory cortex to tell your brain that this has actually happened to your finger. So it localizes it. Other areas go to the amygdala, which gives a kind of an emotional response to the pain. So you might get upset or agitated or sad, depending on the response. Some go to other brain centers like the hypothalamus to cause a sympathetic reaction. Heart rate goes up, blood pressure goes up, breathing goes up. Okay, so this is perception. But what your brain can actually do is modulate it. So it can actually say, you know what, there's some bad pain here. We need to keep you alive. So what I'll do is I'll try to drop some pain away. So I'll send some signals back down to that synapse, so to this area here. This is what this blue one is. And what I'm going to do is I'm going to release some neurotransmitters, particularly, and this is the one I want you to focus on, this pink one called an opioid, because we have our own opioids. So we have endorphins and enkephalins. And what this purple one can do is actually come out and bind to the primary or the first order neuron, and actually the second order, and then it can actually stop the transmission of pain signals. And so that's a good thing because it can help with removing pain, particularly in an acute setting. So that's the pain pathway. How can we utilize this pain pathway to help with analgesia? So if you go to the section in the course site where we look at analgesia, and this is the management of pain, the drugs used, and we look at the WHO analgesic pain ladder. And what you'll see is there's 2 main steps. There's mild pain, moderate pain, severe pain. So for the mild pain, we generally will refer or use NSAIDs. So you guys already know what NSAIDs are, but I will go through on how they can work. So NSAIDs here, non-steroid anti-inflammatory, such as ibuprofen. So we know if you were to either burn yourself with lots of heat, that would cause nociception, or if you pricked it with a thumbtack, that would cause nociception, or if you put it into a bucket of ice, that would cause pain, cold pain, or if you were to bang it in the door, that would cause a mechanical pain, that would also cause pain. But a lot of these would also cause tissue injuries, which would cause inflammation. This inflammation would not only swell up the tissue, which would put more pressure on the nociceptors, or the pain receptors and cause them to continue to send pain signals, but they would also sensitize the nerve, so make you more sensitive to pain. And in the big picture here is you just keep having pain. So we can actually use NSAIDs to take away that inflammatory response. So we get rid of prostaglandins, because prostaglandins sensitize nerves, so does bradykinins. And by giving NSAIDs like ibuprofen, it blocks that effect. So that can actually be useful in acute inflammatory pain, particularly in a more mild case. So that's how the non-steroid anti-inflammatories may work for milder pain. Paracetamol is a bit more difficult because we don't exactly know precisely how it works, but it's assumed that it works centrally. A theory for how paracetamol works is it may jump on what we call cannabinoid receptors, and that could maybe have a role in removing or mitigating some central pain in particular acute pain situations. Now, moving on to the opioids. So this is step 2, where we have a bit more serious pain and you want to use a bit more heavier things like morphine. So the opioid analgesics that we listed on the course site that you should know is morphine, oxycodone, also codeine, and buprenorphine. Okay, so methadone to a lesser degree. So these guys, what they essentially do, and this is what I need you to know, is they hijack this opioid system that we actually have in our own self. So what they do, see the receptor here, so that there's a receptor, an opioid receptor on the first order neuron, and there's an opioid receptor on the second order neuron. So these drugs actually jump onto those receptors. So this could be those mu or kappa receptors that are opioid receptors. And what they do, at least for this one here, I'll just remove that so you can see what I'm drawing. So this one here, by jumping on that receptor, so by putting, let's say, morphine on that receptor, what it does is it stops calcium entering this nerve. And remember, calcium, if you remember from AMP, is important to release the neurotransmitters. So without calcium, the neurotransmitters can't be released to go across to the second order neuron to send the signal on to the next neuron. So it stops that working. Morphine also, or the opioids also jump onto this one here, and that stops sodium, or sometimes potassium, moving, and therefore depolarizing the second order neuron. Therefore, again, a reduction in the transmission of pain. Okay, so that's important to know that the opioids generally will work at this central level here, and we zoom in here, on the opioid receptors by either stopping calcium effluxing into the first order neuron or to stop action potential in the second order neuron. Okay, now the other example is fentanyl. Fentanyl seems to have an effect more on the NMDA receptor, which is, let me remove some of this off, which is right here. And so by blocking this receptor, again, you stop the action potential in that second order neuron, which removes that the pain transmission going up to the brain. Opioids also will work up in the brain level as well, and they just affect kind of the perception of the pain. Okay, so that's the opioids. Now, what we're left with is the adjuvants. So these are other drugs that can be used to assist in certain pain states that will help remove that painful situation. So the first one I'll go through is the local anesthetics. This is an example would be lignocaine. So let's say at the skin level, you wanted to, you cut your skin open, laceration, you've got the pain, but you need to stitch it. How do you stop that pain? By using a local anesthetic or a local blocker. Well, lignocaine works by stopping the action potential in the transmission phase. So this would be the primary afferent. So that signal going to the spinal cord is happening through action potentials. And if you remember back from AMP, what needs to happen for an action potential to occur? I'll smudge this out over here. So if you had a neuron here, this is the axon going down to the end. To send the action potential down the neuron, we need to make the inside more positive. How do we get something more positive? What's the most abundant positive cation? Well, it's sodium. So you need to get sodium into the neuron. Therefore, you need to get channels open. And lignocaine essentially blocks these sodium channels. So by injecting a local anesthetic into the area where the pain is, it blocks the sodium channels opening. Therefore, we have no pain transmission. And that's the way we can get rid of some pain with local anesthetics. Another thing you can do, and this is not actually written on the course site, but another method that can help is a intervention called a TENS machine. Oops. TENS, TENS, transcutaneous nerve stimulator. Okay. So basically what this is just sends electrical information or electrical impulses through a pad onto the skin and basically bombards the sensory neurons, and it kind of works through the gate theory and kind of overcomes the amount of pain stimulus by sending other stimulus into the spinal cord and kind of overwhelms the body with additional sensory information, and it kind of the pain side of things is not forgotten about, but just less perceptive or sensitive to that. So that's a side adjuvant that can be used. Now, in terms of a spinal anesthesia, this could be like an epidural, and this works in the same way as the lignocaine, but you put it at the spinal cord level. So the epidural is just on top of the spinal cord, on top of the dura, and that uses the same kind of thing. Lignocaine goes in and it stops the transmission through the blocking of the sodium channels. The last one I want to mention is those sedatives or anti-anxiety medications like Valium. Okay, this would be, for instance, a benzodiazepine, okay, or diazepam. So the way that these guys work is it works through GABA channels. And so here we have GABA, I'll go in red, here we have GABA here. And the way that this works is it works on these, so mimics this neurotransmitter and jumps on to this receptor on the second order neuron. And what GABA does when it activates the neuron is it sends chloride into the cell. And we know that chloride has a negative charge. So that means that the inside of the second order neuron becomes negative, which means it's much harder to depolarize, which means it's much harder to cause an action potential. And that basically affects transmission. So the second order doesn't send the signal onwards because it's been kind of depressed. Okay, and so therefore Valium is an effective thing for both nerve conduction but also muscle relaxants, and it's effective in anxiety because it kind of dampens the basically the central nervous system in sending electrical information. The other one that could be used, not so much probably acute pain, but it could probably be used a bit more in chronic pain, is some antidepressants, and that works on serotonin and noradrenaline. And basically what they do is they jump onto these receptors here and also depress the second order neuron to take away the transmission of pain. All right, so we've done all the drugs that we need to in terms of the WHO anesthesia ladder. Hopefully now you've seen how these different drugs work, how the NSAIDs work for predominantly inflammatory pain. You've seen opioids work for more acute pain, and you've seen the adjuvants such as local anesthetics, spinal anesthetics, the sedatives, the anti-anxiety medications. And so ultimately you can now answer this learning outcome on explaining the mechanism of action, how the different analgesic works, specifically in how they work on the pain pathway.